Good afternoon and welcome to your Sheffield COVID-19 Dining at Home Echo. A very warm welcome to all of you and to our guests from outside of Sheffield. Can you give me a wave so I know that you can hear us, please? Just need to move a little bit, thank you very much. If possible, if you can join with video, we'd really appreciate it. And today, our Echo session, if you've not joined us in Echo session, has a particular format and style we're facilitating. We have an expert presentation and hopefully a case later on within this next hour. The title of the talk from our expert today is Doing Things Differently, which you know is a subject close to my heart, but obviously Dr. Sarah Mitchell, who's our expert speaker today, is absolutely an expert in this area.
Hello everyone, I'm Sarah Mitchell. I'm a GP at the White House Surgery and I'm a Yorkshire Cancer Research Senior Research Fellow at the University of Sheffield and also Clinical Director for End-of-Life Care at Sheffield CCG. I remember in the beginning it was a mission. We were having so much trouble, I had to call a major meeting and I had to put it on the table and say, well, this is how it's going to be from now on. If it's not, then I will just complain, do whatever I need to do. They are so busy and overstretched, I think that empathy has gone. These quotes from my PhD research from the family members of children with life-limiting conditions demonstrate much better than I can why I think we need to do things differently to deliver holistic palliative care for everyone who needs it, old or young. Thank you for coming to this Echo session, which is an example of having to do things differently. I'm really honoured to have won the 2020 Society of Academic Primary Care Royal College of GP's Yvonne Carter Award, named after Professor Yvonne Carter, who was a truly inspiring academic GP, Dean at Warwick Medical School, where I've just completed my PhD and a real advocate for palliative care and primary care. Usually, the award would be presented at the SAPC conference, and here are some of my colleagues receiving theirs in recent years. Sadly, this year's conference, which I was excited about anyway, with its theme of living and dying well, has now, due to COVID, been postponed until 2021. So I've been set the challenge of providing a recorded presentation to the Society of Academic Primary Care for the website instead, and I cannot thank Laura and Sandra and the team at St Luke's Hospice enough for allowing me to hijack their session this week and saving me from having to do a presentation to myself at home. I'm a GP and I'm a very early career researcher, having just completed my PhD, and I'm now working as a Senior Research Fellow at the University of Sheffield. Alongside those roles, I'm the Macmillan GP and Clinical Director for End-of-Life Care at Sheffield CCG, and I've held similar roles over the past 10 years when I've mainly worked in Birmingham. So when I talk about palliative care, I always talk about it in its broadest sense and as defined by the World Health Organization as an approach to care that improves the quality of life of those with life-threatening conditions, not specifically a specialist service. Palliative care was recognised as core to the role and identity of primary care physicians in the Declaration of Astana last year. And in the time that I've been a GP, since I qualified here in Sheffield in 2007, there's been a significant rise in the number of patients of all ages living longer with more and more complex multimorbidity, often incurable conditions, often at risk of sudden life-threatening deteriorations. At the same time, there's been policy after policy after policy telling us to do palliative care better, and now with COVID there are even more, but my working environment in general practice has, with the best will in the world, not always been conducive to doing palliative care better, with time taken up dealing with demand at the front desk and managing income-generating contractual activities rather than delivering holistic palliative care in the community. And when we did some research into the experience of GPs delivering end-of-life care in the community in 2016, I was reassured that I was not alone. The evidence suggested that compared to similar studies conducted 10 years earlier, things were getting worse, not better. GPs felt they didn't have enough time with patients, couldn't mobilise enough support in the community, and were lacking training in this important area. So in 2012, when I could take this disconnect between policy and practice no more, I resigned my GP partnership and decided I had to do things differently, and set off to pursue a career encompassing clinical practice, research, and work to influence policymakers all at the same time. Perhaps because I like to do things differently, a lot of my research is focused on children's palliative care, and when I speak to GPs about that, they look quite confused and tell me it's nothing to do with them. That's what I thought too, until just as I was wondering what research was most pressing, I received in my document inbox a letter about a 13-year-old girl at our practice who died. This was a previous practice in Birmingham. As her GPs, we knew nothing about her case, and that was no surprise because although she had lived with 2 life-limiting conditions, all of her clinic letters indicated that her condition was stable. But looking at her notes more closely, she'd been in and out of the local hospital and the local intensive care unit increasingly frequently towards the time that she died. And when she did die, it was following increasingly frequently transfer to the tertiary hospital paediatric intensive care unit and difficult decisions about limitation and withdrawal of treatment. I was appalled that as her GP practice, we had failed to provide any input to her care or support her family. But I soon learned that dying on ICU is the most common place for children with life-limiting conditions to die, most often following withdrawal of treatment. And this is a hugely complex clinical, ethical and emotional situation and quite difficult to talk about, so I do acknowledge that in this presentation. It's also a very hot topic and can be distressing to consider. But did you know that the numbers of children in England with life-limiting or life-threatening conditions has increased from around 33,000 in 2001-2002 to over 85,000 in 2017-18, while numbers of GPs have been decreasing? What that means in reality is that for every GP in England, there are 2 children with life-limiting and life-threatening conditions, so we should probably know who they are. And just to set the scene, life-limiting and life-threatening conditions are categorised into 4 different categories. Life-threatening conditions for which curative treatment may be feasible but can fail, conditions where premature death is inevitable but where there may be prolonged periods where the child is well, progressive conditions without curative treatment options, and irreversible but non-progressive conditions causing severe disability with an increased susceptibility to health complications. So it's a really, really broad group of children and young people. And in terms of palliative care need, they're very holistic and can be very long-term. So, convinced that we needed to do things differently and that children's palliative care is the business of GPs, I set about doing research into the healthcare experiences of these children. Again, I had to face the challenge of doing things differently, and recognising the complexity of this area, clinical practice, didn't really feel that a randomised controlled trial was going to answer the questions I had. So I chose for my PhD to do realist research, an approach that allows us to develop and test theory by investigating hidden mechanisms triggered in certain contexts to lead to outcomes. I did this through literature reviews, followed by interviews with children and their families and focus groups with healthcare professionals. Using realist theory allows you to refine and refute the theory as you go along and come up with policy relevant recommendations. That's one of the main aims of this approach. Alongside my research, I've taken every opportunity to involve young people, and including medical students. And sometimes they have pushed me to do things differently. Like these 5 young people, I drove to Cardiff to take part in a presentation at the International Children's Palliative Care Network conference. And sometimes I've encouraged them to do things differently, like medical student Stephanie, who presented a comic strip poster at the RCGP conference last year and was awarded the Best Research Poster Prize. So what did I learn? From the literature reviews, is that there is some evidence, not very much, to suggest that specialist paediatric palliative care services work for children and young people. Studies suggest that care delivered by specialist services, those supported by trained consultants in paediatric palliative medicine, lead to improved quality of life, improved symptom control, and fewer high-intensity treatments at the end of life. But there are nowhere near enough of these services for every child and family who could benefit from their care, so we need to do things differently. And examining the literature using realist methods, asking the why, who for, and when questions, we can find evidence that policy outcomes are underpinned by the outcomes most important to children and their families. Outcomes like feeling respected, heard and supported, developing a sometimes unspoken understanding that dying is possible, and being able to place an emphasis of care on lessening suffering. These outcomes are achieved when underlying hidden mechanisms, including sharing the emotional impact, feeling advocated for and in a trusted relationship, and the ability of professionals to bear witness to the child's and family's situation and affirm difficult decision making, are triggered. And these mechanisms are triggered when the expertise of children and family are acknowledged within established and trusted relationships with healthcare professionals, an aspect of care that we don't often see spelt out in palliative care policy documents. So after thinking about this theory and developing the first theory, I did serial interviews with children and families and focus group with healthcare professionals. And what I learned from this is that at the interpersonal level, families experience permanent and sometimes catastrophic change in the family narrative when their child's diagnosed with a life-limiting or life-threatening condition. The child does not wish to be defined by their condition, despite the impact it has on their life. They would much rather talk about their own priorities than healthcare or illness, and in healthcare can sometimes be unheard. Over time, the child's condition and care become a family vocation, home becomes a healthcare system, and the family become experts in the child's care, and this can be at a cost to the parent's sense of identity. Meanwhile, families' hopes and expectations are shaped by repeated and sudden and anticipated deteriorations in the child's health, followed by periods of recovery, and this becomes normal. Key personal relationships with clinicians are developed, those who care for families with trust, respect, advocacy, compassion, and ability to bear witness to the family situation, and those who go above and beyond are all highly valued. At a healthcare system level, every family I interviewed described fighting the system in order to obtain the care their child needed. The specialist system, although vital for expertise and treatment, was experienced as fragmented and difficult to navigate. Children and families are aware of the fragility of their situation, but death was rarely mentioned, and inadvertently children and families and clinicians entered into a collusion of immortality, where everyone was trying to fix the child rather than consider the possibility of dying. Even when death was discussed, for example in advanced care planning conversations, it was a relatively abstract concept from the perspective of children and families. Palliative care was most definitely conceptualised as a separate specialist service, bolted onto their usual care in some way. And there was a P-word problem, with that word having such negative connotations that it was difficult to raise. The benefits of healthcare professionals being alongside families in this tough situation were clear. And that wasn't just specialist palliative care teams. The inputs of GPs and other teams, like community nursing teams, who could share the emotional burden and listen to listen rather than listen to fix, was highly valued too. Specialist palliative care teams had a role not only in the provision of hands-on palliative care, but being alongside colleagues, legitimising and role modelling the approach, and in some cases illuminating the blind spot of palliative care. And a key factor in developing and improving palliative care was the buy-in of organisation and system leaders. So, putting all this together and suggesting a theory that works for policymakers to suggest what needs to be in place if we are to achieve policy outcomes, we can consider the child and family at the centre as experts in the condition and its management, but in a highly vulnerable position. They wish to be heard and supported and feel looked after, and this can be achieved through those trusted connections and key interpersonal relationships with healthcare professionals. It can be any healthcare professional in theory, but managing palliative care as a broad approach or through referrals to specialist services depends on the commitment and engagement of healthcare professionals as individuals, their approach and their ability to bear witness to the family situation and share that emotional burden. The presence of specialist palliative care teams enables this further by legitimising and role modelling or shining a light on palliative care as an approach alongside, not instead of, other treatment. The commitment of organisational leaders in every healthcare organisation is also key, through a clear display of that commitment and open approach to palliative care. This can lead to the development of services, but if it also values the time and space required to develop the key relationships at an interpersonal level, or are commissioned and contracted in such a way that this is prioritised, that would be even better. And that's my theory of how we can improve palliative care and achieve the more black and white policy outcomes. Doing things differently, including prioritising palliative care for children and families, and in fact anyone who needs it, recognising that children and families want to be heard, that they are experts, highly individual and do not always fit criteria, prioritising relationships with healthcare professionals and the context that enable these, nurturing and supporting professionals within all specialties who have an interest or desire to deliver more palliative care, champion compassionate organisational culture and engage committed system leaders. And what about general practice? Well, three key themes emerged from the interviews in relation to general practice and primary care. Firstly, that poor experiences of general practice contributed to children and families feeling isolated. Secondly, that they valued support from general practice. And thirdly, that general practice has the potential to provide important aspects of care. Children and families have developed their own strategies for accessing that care, and the recommendations for primary care that are really very simple were to foster relationships with the families of children with life-limiting and life-threatening conditions, get to know the children when they are well, using opportunities like chronic disease reviews or medication reviews, and proactively offer their repeat prescribing and medication reviews where possible, involving the whole practice team. So there were examples of practice pharmacists being very involved and helpful for families. Weirdly, COVID has given us new opportunities to make contact and engage with these children and their families by proactively identifying them as high risk and vulnerable and supporting them with shielding and protecting themselves. The updated guidance for young people came out last week, and there are many more significant concerns about the impact of COVID on young persons' mental health and education and safety that we could also be more tuned into. So what next? Since completing my PhD and starting in my new roles in Sheffield, and with the arrival of the COVID pandemic, it's been important to think about doing more things differently, and my current main focus is on primary palliative care and whole system change for improving palliative care in the city. Primary palliative care is an area which I've long thought needs more attention and to be much better aligned with wider healthcare system plans for palliative care. Primary care physicians have the skills and potential to deliver palliative care integrated into every patient contact in the community, an issue that we highlighted in this BMJ editorial last year, pre-COVID. One of the co-authors on the article was Dr. Amy Tan, who is an academic GP and associate professor in the Department of Family Medicine at the University of Calgary. And eventually, when travel can happen again, the funds from this award will allow me to go and visit Amy for us to share experiences and some research data, hopefully, and build collaborative research in primary palliative care in the future. Until then, and during the COVID-19 pandemic, the work I've been doing at the CCG with colleagues in Sheffield from both primary and community care and our specialist services locally, and a rapid review that we undertook about the role and response of primary care and palliative care provision during pandemics, which showed very little research in this area during previous pandemics, continues to highlight the need for more clinically led research to inform practice and policy, both through the next phases of the COVID-19 pandemic and into the future. So finally, and just before questions, I have to say a big thank you to all of the children and families who have been involved in my research, both as participants and as PPI advisors. Their stories will stay with me forever and inspire me to do more. Also to my amazing supervisors and mentors at Warwick, Professors Jeremy Dale, Anne Slowther and Jane Code, who've pushed and encouraged me to take on new challenges, often with the words, "You can do it." And now here in Sheffield, my fellowship supervisors, Caroline Mitchell and Sarah Danson. If I've inspired anyone here on this Echo today to consider doing more research or policy work as part of their career, that would be fantastic. And my contact details are here on this slide. And I'll finish just with a quote from Professor Yvonne Carter, published back in 2002. "Those doctors who have completed vocational training and have a general practice or primary care background have as much to contribute to the specialty of palliative care as those from an acute hospital-based background." I do think those words, which also apply, of course, across primary care to community nurses and all the other members of the primary healthcare team, are as relevant now as they ever were and must be an integral part of the conversations about how we can do things differently going forward. Thank you very much.
Thank you, Sarah. Thank you, everybody, for listening, and thank you for a lovely presentation. Everyone was very engaged and nodding a lot. Yeah, thanks. Thank you. Has anybody got any particular questions for Sarah or any comments? If you want to raise a hand or just give me a wave if you're going to unmute yourself. Andrew McGinty. Hi, Andrew. Do you want to unmute yourself?
Hi, yeah, that was a fantastic presentation. Thank you, Sarah. I was really interested in the bit you said about the kind of the role of the GP and actually it being more than just the GP in primary care. And I wonder whether some of a GP's hesitance or reluctance, there's a kind of clinical impotence in terms of the parents and the family and the child being kind of the experts, knowledge holder in the condition that the child has. And actually whether the key is more for GPs to think of the general word than the practitioner, because I suspect in the children that we have here in Woodhouse that I think of with life-limiting conditions. I'm more of a broker between the family and agencies like pharmacists and community support workers and other sort of ancillary services, rather than me giving clinical input directly to the condition of the case. But it's that sort of, it takes knowing them for a long time to feel happy to be a broker rather than a practitioner. And I wondered if you'd any thoughts around that.
I do completely agree with that sentiment, Andrew, about the general part of our role. And I think partly this relates to that sort of very highly specialist and fragmented system. Is when we get a letter, it often will spell out the names of the particular conditions that a young person has, but it rarely spells out the impact that that condition has on the young person's life or the family's life. And that's where I think we really do have a role in looking at that, taking that more holistic view. And I wonder what opportunities will come, following COVID. I think it would be interesting to encourage our specialist colleagues to join us in doing some of that thinking, holding patients more in the community. I know we've spoken a bit about the patients coming to primary care for their consultations so that we can then access their specialist support around them. And that just might be interesting.
Okay, thank you, Sarah. Chris Burton, do you want to unmute yourself? And I'll come to Laura.
Thanks, Sarah. Thank you. There was a word that you used right at the beginning about establishing a relationship, where you said establishing a trusting relationship. And I wonder if you could elaborate on trust and what it is. And maybe it links into Andrew's previous question. But I think that trust is such an important bit of the relationship, and how it might be built as well as how it might be lost would be useful.
So I think these children and young people had different challenges almost every day sometimes, so whether that was in navigating the system or in some new challenge that had come related to the condition, some change in their health. And the system wasn't always easy to access, so they often would end up in A&E or wherever it was. And in the sort of dealing with the daily chaos, there was a sense that they needed to fall back on that trusted relationship. They needed to feel like somebody had got their backs. Now, and that to me, you can call it holistic palliative care, you could call it any kind of holistic care really, but it was that was what they wanted to be able to trust in. It was very, very often for these children and young people who did have palliative care services, it could be the specialist palliative care nurse, it was often the children's community nurse, and it was very rarely a GP, but it might have been in the past.
If I can just follow, there's a resonance when you said it's that somebody's got my back, which is exactly the phrase that I heard from somebody talking about what young people with mental health problems value in a support worker. And more than anything else, it's a perception that someone's got your back. And I think that is, yeah, I would agree with you that sense of being someone who's there and who does stuff. Who's not just there, but who's not necessarily does the frontline stuff, but is able to kind of read the situation and work with it. Yeah.
I think the other reflection is that they're so often in navigating the system with encountering people listening to fix. So there was always a fix. There was always some sort of medical solution, an onward referral or a new drug or something. Yeah. So we weren't listening. They were not experiencing listening to listen. Yeah. And sometimes they needed listening to listen for someone just to hear and validate their concerns and, share with them what they were going through.
Great, thank you.
Okay, thank you. Laura Smythe, you raised your hand.
Thanks, Sarah. Really lovely presentation. I was struck by your discovery that every single family who you interviewed had felt that they needed to fight the system. You've talked about listening to listen, but what else can we do to help these families? What were the issues that they needed to fight for?
So it was different for each family, and there were sort of acute fights and longer term fights. So the acute fights might be my child's in pain and I need someone to help me right now. And the families, they did acknowledge that sometimes there wasn't an easy drug fix and they just wanted someone to be alongside them in that situation, and that often, of course, happens in that was much more a hospital environment kind of issue than we would perhaps be involved in as GPs. But the longer term fights were things like accessing equipment, or it was all the same things that we see with our older patients. The accessing care in the community, that sometimes finding that they couldn't get a repeat prescription quickly, perhaps because the primary care team had misinterpreted some new guidance from the CCG about what they were allowed to prescribe and not, what was a special drug and what isn't, costs of some of the treatments. That was one example that came up a lot. Transition came up a lot, and fears about what would happen when they went to adult services, and actually interpretation of the word palliative from children's into adult services was really interesting, because palliative to some adult practitioners meant we don't give you, all these different very highly complex treatments in your home. So those were the sorts of fights, and I suppose, I think that, again, that feeling like someone's got your back as you're taking on those fights was really, really what was missing for a lot of the families.
Okay. Is that okay, Laura? So if we come to Shami next, please, and then we'll go to Andrew and Yo-Yo. Shami, Dr. Musa.
Thanks, thanks for that really great presentation, Sarah, and congratulations on your award. I guess working in Page Hall's a bit of an obvious question, but was there any ethnic diversity represented in the patients that you looked at, and were there any non-English speaking families you spoke to?
I didn't speak to any non-English speaking families because my expertise in qualitative interviews through interpreter is a learning need. That's one for the future. But there was ethnic diversity. I carried out the study in Birmingham, so I did have quite a range of different backgrounds amongst the families. A lot of them had, several of them had English as a second language.
And did you see any differing themes coming through from those different backgrounds?
It's not something I specifically compared, because the themes was pretty much overarching and related to the conditions that the children had, and that really significant change in the family narrative when the condition came along, regardless of background. But I think it would be a really interesting area for future research, because of course actually the prevalence of life-limiting and life-threatening conditions is much higher in certain ethnic minority groups, as you know.
Okay, thank you. If we just come to Andrew McGinty next then, Andrew, thank you.
Hi, thanks. Sorry to pest you again, Sarah. If I haven't said it already, congratulations. But I was wondering, even in the time frame of this piece of work, have you any thoughts on the effects on this topic, or the impact on this topic of the sort of changing landscape of primary care? So I'm thinking of the fact that we're moving away from a largely kind of long-term bought-in partner GP model of care to a much broader MDT type team within a general practice setting, where you may have a heavier dependency on locums salaried partners who may be part of a practice for a fixed or shorter period of time, physicians associates, prescribing pharmacists, prescribing nurses, empowered healthcare assistants, all that can play a critical role in that relationship that you described, not having to be with a general practitioner, but maybe more transient in their time within that practice setting, and whether that may have an impact on the child and family's experience of their care.
Yes, good question. I think that it certainly, there could be impacts on that new ways of working, and they could be both positive and negative. And of course, the risk with that is that hearing from the families that they wanted that feeling of someone having their back, so that they don't experience that. But if we, because of the lack of continuity in the workforce, but if we really skillfully built virtual MDTs around families, from both primary care and specialist care, then actually they could have a very good experience of care. And I think with the GP networks, evolving and emerging and working out how much, they want to take on at a network level, making sure children are in the conversation is priority number one, perhaps, but also thinking about models of nursing care around these children, young people and their families, working out whether we can do things differently so they don't experience that huge change at transition. These are all exciting possibilities going forward.
Okay.
Thank you.
Okay, so just come to Yaya and Caroline, then up to Jo, if that's okay. So Yaya, do you want to unmute yourself? Hi.
Hi, Sarah. Thank you for that great presentation and congratulations on your award. I was just going to ask, how did the families view the role of the practice pharmacists within this, and the pharmacists act as a bridge to primary care, to the GPs?
So prescribing generally came up quite a lot in the study. The role of the practice pharmacist was spoken about really just by one family who'd had a really, really positive experience with when the letter came into the practice. The practice pharmacist would spot the medication change and then proactively contact the family and say, you know, don't worry, we've got this, it's sorted out, blah, blah, blah. And that gave them a great sense of security. But again, a whole load more research to be done in that area, I think.
Thank you.
Okay, thank you. Come to Caroline Mitchell. I don't unmute yourself, Caroline.
Congratulations, Sarah. Just briefly, I mean, I think that you've also touched on what is palliative care and what's that mean to families. And when we talk about transitions in care, in our practices, we have palliative care registers, which, you know, mostly would exclude and wouldn't necessarily include children with life-limiting conditions, but would provide a forum to involve GPs more directly. Is there something we could reflect on or think, and how to have those conversations? You know, from the way from your talks to families, how do we have those conversations? Who has those conversations, and when do we have them?
All really, really tricky issues. I agree about the palliative care register. I think palliative care meetings and practices could be a really great opportunity for us to consider those young people with complex needs and palliative care needs. I think part of the challenge is the palliative label, and in fact, you know, in our own practice, with part of the transition project, the Royal College GPs and Together for Short Lives are doing a sort of transition pilot project to explore exactly this, how we use that palliative care meeting as a forum to work out how we can support families better going through that. We've collected a list of young people and we can't quite manage to put them on the palliative care register because that doesn't feel like the right label. It's the label, you know. So I think, you know, we're still thinking about that, but supportive care or something like that might be what we use so that we can find them quickly. And the conversations bit is really, really hard, and I'm not sure that I think we can contribute to part of those conversations as a dynamic process. You know, when families have one conversation with a practitioner and they come away and reflect on what has just been spoken about and they need somebody else to bounce it off, whatever, we could possibly be part of that as a team. I can't imagine we're necessarily leading it.
Just go back to Caroline then. Do you want to unmute yourself, Caroline? Okay.
Thank you very much. That outlines the importance of co-producing, co-designing that, you know, the terms we use, the times, the where, the when and who. We need to do that, don't we, with young people and their families.
Yeah, absolutely.
They're
the experts. They take the lead.
Yeah, they're the experts by experience, and we'll make a better job of it if we don't centre on what our needs and concerns are.
Yeah.
Thanks.
Okay, if we just come up to Jo Hopkins, I'll come to you, Andrew, and we've got another hand up, and we'll look at Chris Burton's also written a comment down for us. We'll come to that. So, go, Jo.
So, thank you, Sarah. I wanted to pick up a little bit on what Andrew McGinty said about the long-term care. If you are a GP, it's a great privilege, isn't it? We have the care for the patient in front of us, but we have the care, if we've been somewhere a long time, for families over the years, and that often is how that trust is built up. So I had a little girl 20 years ago now who died, and my relationship with that family, I have to say, has been a huge privilege. But that's because I've been there, like Caroline, for 30 years. And so I'm a great advocate for staying in the same place if you're privileged to do that, because you build up unbelievable trust with these families. I know why they come and see me in February each year. The little girl died on the 2nd of February 2000. I know that probably one member of that family will come that day. They may not even mention her, but we both know exactly why they've come at that time. I know why the other 3 children come with things that really are not worrying, but they're worrying to them. Their eldest sister died. So it's a massive privilege. The second point was just about the Asian patients that Shami mentioned. I've huge respect for my Asian families, the way they care for their children who have life-limiting illnesses. They are extraordinary. One family, it's a consanguineous marriage, and 2 of her children have died already, and another child is very likely to die soon. She is incredible. What that Muslim lady teaches me is absolutely extraordinary. I rang her recently because of COVID. The child's got lung problems, and she was so grateful to me for ringing her. Well, how humbling is that? You know, that is the beauty of general practice. So I know I need to go back and make sure that we have got a list of these children, that there aren't children out there that may be being seen by Bluebell Hospice that we don't see regularly, and I think there are, and make sure that every single one of those children on that list that you talked about has got a named person that just touches base with them every now and then. So thank you very much.
Thank you. I think also you've just outlined lots of the reasons why we need lots more primary care research too, so that the value, you know, like you say, that privilege, the value of those relationships is really better understood and has a much higher profile, I think.
Thank you, Jo. Just come to Andrew McGinty, and I'll come to Paul Johnston.
Sorry, I can't help myself asking questions. It's sort of picking up on the last conversation and Caroline's conversation. I'm getting to the sort of so what stage of thinking about this now, and I'm not our palliative care leads, but I bet you Caroline and I and my other partners could sit down and name all the children. And actually, it's not just children now. Some of them are in their early 20s that are young people who have these sort of life-limiting conditions, and I'm beginning to get a sense that you know, where I might think of adults and older people in that surprise question as defining my palliative care register, that doesn't seem the right tool to articulate who these children and young people are. But yes, all of us, I mean, I've not been here as long as Caroline, nearly 20 some years now, but we could all sit and name all the kids and young people that I think we would put on our list. But that's because we know them, and that's different from having a tool that helps identify them. And I wonder, is that something that you're going to be thinking about, or somebody could be thinking about, in terms of how do we take that tool, that wheel that you've articulated, and start to actually make it physically workable?
So I know there is somebody doing their PhD on, you know the SPIC tool, the Supportive and Palliative Care Indicator tool, and they're looking at children and young people's version of that. I think, though, from my point of view, you know, I put that list of the categories up, but I spoke to children and young people who didn't fit neatly into those categories. What they all had in common, though, was they had complex, highly individual conditions that were very unpredictable. And I think there's a massive parallel between that and our complex, multi-morbid, elderly, frail people. So we already, you know, we've got this quite challenging population to be delivering palliative care to, and the surprise question and that sort of time frame way of doing it is, I think, probably out of date.
Okay, thank you. Andrew, just take a last comment from Paul Johnson, because I'm also very aware that I'd like to introduce Professor and as well to actually give you your award, Sarah, if that's okay. Barring a very humbling set of conversations and reflections. So Paul, do you want to go ahead?
Yes, I don't want to delay the award. It's
not here anyway. So just the people.
It was just reflecting on what you mentioned as some of the key points that had come across in terms of fostering relationships with families and getting to know children when they're well and being involved in the everyday care. And this links with what you were just saying. We do this and we value this. This is core general practice for particularly for patients with long-term conditions, and this is what we do without thinking about it for other patients. And I just wonder if it came across with your conversations as to why GPs perhaps don't. Are we thinking there are lots of other services involved with these patients and they'll be getting all the care and support and they don't need to spend more time coming to see us? Is it because we sort of shy away from being proactive in approaching them and offering the sort of care we would be providing normally? And did that come across at all?
Yes, and there were different reasons depending, because I did interview children with quite a wide range of different conditions. So, you know, for some of those children and young people, their care was very, very specialist led, quite rightly. That doesn't mean we don't have a role in supporting the family in the background, but while they were having treatment for their you know, complex cancers, they were spending so much time in the hospital that it was all focused on that. So the other, some of the other children and young people I interviewed had much longer, long-term disabilities, and these were the strategies that they had come up with over time. It was rarely a proactive offer from primary care, and I suspect some of the barriers are things like we don't feel like we know the condition very well. Yeah, exactly, we do think they've already got specialists all involved, and I also think our contractual obligations are not in this direction. You know, some of the things that have, in the recent past, taken a lot of our time is not providing holistic palliative care to children and young people.
Yeah,
so
thank you.
I'll work on that with the CCG. And if anybody wants to join the transitions pilot with the White House, Page Hall, and Pittsmore are doing it so far, but the more Sheffield practices we can get, you know, interested and involved, the better.
Thank you so much, everybody. Thank you, Sarah. And so can I ask Professor Carolyn Chew-Graham and Dr. Nick Thomas, I just like saying that, to unmute yourselves and go ahead with your presentation for Sarah. Thank you.
Thank you so much. Sarah, what a fantastic and very moving presentation. And you had a lot more chance for questions doing it this way than you would have done it at either SAPC or RCGP, and you answered those questions really well. Thank you for mentioning the poster award that was made at the RCGP conference last year. I was part of the judging panel for that, and it was really a great poster. So just to reiterate about Yvonne Carter, she was an outstanding and inspirational leader, and she had a remarkable impact on academic general practice. And after she died, it was decided that her contribution to primary care research should be put in place so that it was recognised, and the Scientific Foundation Board of the RCGP and the Society for Academic Primary Care jointly instituted this award for the outstanding early career researcher. And this has now been going for 10 years, and we're actually updating the award. So next year there's going to be 2 awards, one for a clinician and one for a health services researcher. But currently the award is a one-off, and Sarah was an outstanding application. She obviously works on palliative care, but the application outlined all the PPIE that you had, and particularly involving medical students. So you were the obvious winner this year, Sarah. The award is supposed to enable early career researchers to have some international travel experience, not just to go to a conference, but to develop a true collaboration. And you mentioned Amy Tan, and I do hope, Sarah, that you will be able to go out and see Amy when the restrictions are lifted. So I'm going to hand over now to Nick Thomas from the RCGP, because he's going to present the award to Sarah.
Thanks, Karen. Yeah, if I just say, I mean, we had some amazing candidates as applications. I couldn't believe what I was reading through it, actually. It was a privilege to read them all. But Sarah, yours was just exceptional, just incredible, actually. And the work you've done off your own back, actually, I think, as well. You didn't come through the traditional academic route either. It's very safe to say that one. And that was certainly really important to us as all academics, and even just I'm a jobbing GP in West Oxfordshire, and it gives us all hope, I think, actually, that we can all become, or even be a part of what you've become. I think is incredible to see, actually. And you had an SFB Practitioners Award, if people aren't aware of what that is. That's a small little SFB award to get people started at the very beginning of their academic careers, and it's open to all GPs to apply for. So just want to give that one a quick dig. All of your awards, your keynote speaking, all of just incredible, and what you've become now. And I also read, I think you were a CCG clinical lead as well at one point. I mean, just incredible. And with a family on top of that, how you do it, I have no idea. But anyway, on behalf of the Royal College, it was just simply stunning, an absolutely outstanding GP, and we are privileged to give you the award, the Yvonne Carter Award. And thank you ever so much for applying. Thank you so much.
Thank you. Thank you for supporting this virtual presentation too.
It's been wonderful.
I think speaking for everybody, Sarah, sort of saying it was a real. I had the opportunity to see your slides, didn't I? It's been a real privilege to hear you speak and to hear how you have been inspired by the families that you spoke with as well, and to hear everybody sharing their experience really today. I don't know, a huge thank you to Professor Carolyn Graham and for Nick Thomas for joining us today, and for all your academic department colleagues and those people who support us all in Sheffield. Sarah, it's such a lovely opportunity today to see such a broad cross-section of general practice and palliative medicine in Sheffield. So, Sarah, do you want to have the final few thoughts at all? Is there anything you'd like us to remember from today in particular? I'm not putting you on the spot at all, but I'm quite good at doing that. So.
I just want to say thank you very much to you for letting me hijack this session, and to everybody who's joined. And I'm really, really happy to hear that people are thinking about how they can take some of what they've heard back into their practice. And I hope that we can really, support and care for these children and young people and their families in Sheffield and set an example nationally going forward. That would be amazing.